Okay. Good morning again. I'm super excited to be here. I'm even more excited to see such a robust turnout and the enthusiasm and energy that I experienced this morning. So thank you for inviting me. I think there's a lot of work to be done, and I'm really happy to be part of it. I initially planned to focus on a more sort of holistic approach for the presentation with regard to health and climate change. But that took a rapid change for me several months ago with what happened this summer. This summer, we have literally witnessed extreme heat transition from an unassuming, invisible public health crisis to a full-blown human rights issue. And by the way, Texas is ground zero for that. So with that in mind, and with that perspective, I decided that I would be remiss not to focus. So most of what I have to say will be specific to extreme heat, but I should say that will provide a foundation. Many of the same problems and challenges that exist in extreme heat also manifest in other dimensions of climatic health. I'm going to adopt the theoretical framework that the conference has provided, the good, the bad, the wicked, because I think it works really well for what I have to say, although I'm going to go out of order. I'm going to start with the bad, and my spoiler alert is this: most of it's bad. I'll then transition into the wicked problems, if you will, wrap up with the good, and then I will circle back to lay out a prescription of change. And intentionally, my prescription of change is designed really to sort of put some ideas and concepts and paradigms in front of you that hopefully will provide a concept for discussion, debate, etc. I've found that this area is changing on the dial, literally. I wake up every morning and there's a new event. So I think keeping that framework within that sort of flexible context probably works well for where we are now. Okay, so before delving into the bad, I want to just set the context. I'm an anthropologist, and so most anthropologists will tell you that context is everything. It's basically the fundamental for shared communication, and so I want to establish sort of that we're all at the same starting point. And I love this quote by Bateson, because it really does articulate how critical context is before we can move forward. He's probably most known for being Margaret Mead's third and final husband, but he was an anthropologist in and of himself. He did some great work. Okay, so where are we? Extreme heat is a lethal public health issue. If you look at all of the series of climatic issues that transpire within, the North American continent, hurricanes, tornadoes, fires, etc. By far, extreme heat has the highest mortality, and that's been true for the last 30 years. And again, on the heels of this summer, it'll be really interesting to see those numbers. One of the challenges, and I'm just going to lay this framework with understanding that connection, is invisible. It's an invisible problem. We don't have before and after pictures like you do. I'm from New Orleans, Katrina, or what we've seen in Maui. When we show pictures of before and after catastrophic extreme events, the community looks the same. And so that has been one of the challenges in our media-focused world. What we do know about extreme heat, and by the way, what we've known for a long time, is that it impacts and affects every single system in the body. Psychiatric, immunology, it's particularly hard on kidneys, so renal, cardiovascular, respiratory. Every single organ in the body is affected and impacted by heat. And we don't have, most of you are familiar with the Goldilocks syndrome, there's not much leeway. In addition, we know that there are medications that the vast majority of Americans take, diabetic medications, antipsychotic medications, blood pressure medications that are also impacted by heat. And we know, again, there's solid evidence-based data to demonstrate that when ambient temperature increases, violence increases, domestic violence. We see there's some really interesting data if you want to look at hatred on social media, increases on high ambient temperatures. Extreme heat is not good for human beings in the way in which we engage with each other. We also know that extreme heat, like most public health issues, is an equity issue. Public health has a very spot-on way of foreshadowing, revealing, and articulating social and economic disparities. We see this in every type of, most of my background is mostly been in trauma and infectious disease. We see this in heat as well. We know, for example, that Black and brown communities are adversely impacted by extreme heat. Some of that has to do with historical issues like redlining, others have to do with the poverty and access to health care. We know that there are vulnerable groups, elderly, children, workers, I'll talk about them in a few minutes. And we also know there's some really interesting data, and I should emphasize that much of what we're doing is really new. We have solid data that shows these links empirically, but a lot of what we're discovering is new within this domain. We know, for example, one of the more things I'm fascinated about is that if you look at what's happening in Europe, the heat waves over the last couple of years, there's disproportionately higher mortality and morbidity for women than there are in the United States. We don't see that trend. So there's really interesting work looking at that disparity. Is it thermoregulation, or their cultural practices, or is it surveillance and reporting? My guess is it's probably all of the above, which makes it a little bit more wicked. We also know that ED visits and hospital admissions spike sometimes dramatically during heat waves. We've seen that this summer in particular. We've seen it for a long time. The public has seen it this summer. And we know that these, again, can be quite dramatic. I'm not going to talk about one of the studies. Let me mention this because I think it's really an interesting one. Last year, JAMA Psychiatric pushed out peer-reviewed publication by which they looked retrospectively 20 years of data specific to ambient temperature, ED admissions over the nation, and they found that the correlation was positive and in some cases quite high, and it particularly was true for bipolar 1, schizophrenia, anxiety, depression. I think there were others. This year, in July, Lancet published another peer-reviewed publication that showed with as little as a 1 degree increase in ambient temperature, it was a risk factor for depression and anxiety. And these empirical studies, again, play out throughout. It affects every single organ in the body. We see it with admissions. And as a side note, I'm not going to focus on air quality per se because there's so much to cover here. But what we're seeing, we're just starting to get the data coming out of the wildfires in Canada. New York, on the day, the worst day of the ambient temperature, because it also affects air quality, had an 81% increase in hospital visits for asthma. And they only looked at asthma, they didn't look at the other issues. From a national perspective, because the jet stream, of course, can impact where the wind blows, and asthma is particularly sensitive to that. Overall, nationally, there was a 17% increase in hospitalizations. Mortality data is complicated, it's controversial, there are some political issues, and we'll get to that in a few minutes. But if you look at the data, what you're going to find is anywhere from a low of 702 Americans die every year from heat-related illness to up to 10,000. I'm pretty confident that the 10,000 number is more accurate, and it itself, many experts will agree, is probably an underestimate. And then finally, and this has become a new approach in the work that I do, because all of those other data and numbers that I just cited, we're not doing much about it. This, I think, the cost, we've got some really interesting predictive statistical models that have been used to now begin to look at health-related mortality and morbidity. And with the hospital admissions and ER visits, it's estimated that it's going to cost each year that many billions of dollars. So that tends to get stakeholders' attention. Bottom line is that extreme heat, in contrast to some of the discourse that I hear, is a real public health issue. It's not about being uncomfortable. It's not about manning up. It's not about inconvenience. And it's not going to be solved with cooling stations or with hydration therapy. This is a major public health crisis that has been for a long time, and it's destined to get worse. And of course, the sub-theme for that is it's about equity. People that don't have air conditioning, by the way, that's a short-term solution, as I'm sure most of you can appreciate, needs to be addressed in that context. Okay, so let's look at the bad. Again, that's my spoiler alert. I'll probably spend more time on that. I really had to prioritize because, quite frankly, there's a lot of bad news. I'm just going to throw out these four concepts because I think it sort of demonstrates the wickedness of the problem, if you will, the complexity and the different strands in which it manifests. So one of the main problems is surveillance. Now remember, medicine prides itself and has for the last 20 years on being evidence-based. And yet, we have this faulty, erroneous system for capturing data. Basically, they use ICD codes. It's somewhat tedious. I'm not going to go into any details. I'm happy to do that at lunch. I love to talk about it. I'm happy to do it while I'm here at the conference. But suffice it to say that the way in which we're capturing data is problematic and it's not fully representative of the problem. In order to fix this problem, the surveillance problem, it's going to take, like many of the issues we deal with, all of you deal with climate change, we need to think outside the box, we need a new paradigm, and we need a new vision. And that's part of the challenge. I've got an idea. I'm working with a colleague at UTD on this particular problem, a doctoral student. But the takeaway is that if we're not accurately measuring the reality of the problem, there are funding issues, there are boots on the ground issues, and it's misrepresentative of the scale and magnitude of the problem. The other problem has to do with, I can't see my notes, is it training? Don't get me started. Training is really interesting because I spent most of my career, my first position was as an assistant professor at UT Southwestern in Dallas in the PA program. And what happened 20 years ago when I first started my position and today, in terms of how physicians and nurses and providers in general are trained to look at environment and health, is squat. And here's the irony. Even though the World Health Organization considers climate change and health to be the biggest challenge to humanity, we don't have surveillance. We're not even training providers. It's hard to get numbers because most of the data for who's offering courses on environmental health is voluntary, and medical schools typically will submit it. But the range seems to be anywhere from 6% to 23%. And most of that includes a course, a lecture, and it's almost virtually all of them are on an optional basis. So we've got this notion that this is the most serious problem facing health in general over the next century, and yet there's no training. If you don't train, then screening becomes a problem. Providers are able to engage with patients because they ask questions. They call it H&P, health and a physical. And during that process, you're collecting data. Where do you live? What do you do? What medications are you on? Virtually no screening tools to date exist for capturing data on heat-related. I recently did an interview with a nurse. She had spent 16 years working bedside and during COVID had moved to home health care. And she was lamenting over the challenges and the problems with heat in her patients. And I asked her, well, where did you get trained? How are you getting this information? And she said, the training that I got to deal with these patients and the heat problems that we were enduring came from the YMCA when I was 16 years old working as a lifeguard. And I'm sad to report, if you're not training, you're not screening, that's what the result is. So you have physicians and nurses who themselves are scampering for information, and how do we integrate it? The final bad that I'll call your attention to is what we call PSAs, public service announcements. The way that we educate the public, the way that we educate patients is through information. When you leave the hospital, for example, typically you're given what's called a tip sheet. And it's instructions, information, do this, don't do that, etc. And what I began to do was to look at what was this messaging about 2 years ago when I first came on board at Texas Trees. And what I found was that it was generic. It was useless. And you've all heard, because I've seen it pushed out this whole summer. It was stay hydrated, seek a cool area. That's public health 101. Generic messaging not only is useless, but oftentimes they can be damaging. I saw this when I first began my career. I was working, as I mentioned, infectious disease ID. And one of the, we didn't know, it was the same thing, trying to figure out who's getting, at that time we even thought patients were at risk, right? And so what the public health system did, and I see it being done now with extreme heat, is they're pushing out these generic messages. Like, for example, use a condom. Well, that might work in certain communities under certain circumstances, but when I was working in the Caribbean, guess what happens in low-income, poor-resource communities? They share condoms. And so when I'm looking at these generic messages of stay hydrated and and I interview people, what does that mean? What are you doing? Well, you just have to drink a lot of liquid. What kind of liquid are you drinking? Well, I have 7 beers. Okay, that's not hydrated, right? Similarly, when you tell someone to go to a cool area, that's not just something that can be done on a bus. I mean, that is not the panacea. So we have a lot of work to do. And the other bad part is the part that we don't talk about. We are immersed in a culture of fear, and that has been on the horizon for the last several years. We have providers who are afraid to say and to do anything and to share empirical data. This has been well documented, particularly with women's reproductive health in the last couple of years. I have watched residents at Parkland, that's a public hospital in Dallas, tell me, I'm really afraid, Dr. Jones, if a woman tells me that she went to another state to have an abortion, I tell her, don't tell me that, we're both going to get in trouble, I'm required to document that. I recently had a physician in Houston tell me, yeah, we don't get into that at all. I'm training the students not even to ask women. I don't want to know when their last menstrual period was, because then I'm going to get into the other potential issues. So I just ask the question, are your periods regular? That's a different question. And that's not how you're going to provide the type of quality health care that needs to be accorded. These are quotes from 2 physicians in Louisiana, OB-GYNs, and you can see what their perspective was. I have seen now, in the very recent past, this same fear become extended to climate issues. I have seen physicians be afraid to form groups and to talk about climate change at bona fide medical institutions. And knowing what I do for a living, they're like, just make sure my name's not there, don't say anything. They're afraid. And there's a good reason to be afraid. These are physicians who are, mostly young, trying to pay off medical school debts. They've got to get tenure. So this is something that we should all be afraid of. I haven't seen a secret medical society since I did my doctoral work and I was doing historical review. It was in the Middle Ages. Okay, now the wicked. I'm going to go through this fairly quickly, and the reason for that is time. I wish that there weren't so many cases to go through, but there are. So let's start with just a quick caveat. The conference is centered around the concept of wicked, which we all know from a climate perspective. It has to do with the complexity, the interrelationships of problems and the difficulty finding a solution, and that holds true for extreme heat as well. But in addition to that, there's this other notion of wicked, and it has to do with evil and malice. And I intentionally mean that to be part of this presentation, because that's what we're seeing. We'll start with the prisons. If you're in Texas, you've seen some of this. We see it in Louisiana and over the weekend in Minnesota. 2/3 of Texas prisons are not fully air conditioned, which means in these cells, many of which are antiquated with a poor ventilation system, you're seeing temperatures of 95 to 100. We don't know exactly why, because these numbers are being reported by the prison system itself. We also don't know exactly how many people are dying in these circumstances. We know that there are currently 41 inmates in Texas who have died this summer, some of whom are in their 20s and 30s, who are under investigation for heat-related death. It's a little tricky to diagnose because you have to have a core body temperature. So if you don't do that quickly, again, you need objectivity to get that, you may not get the diagnosis. Texas prisons are on, state prisons are on record for saying that they've had very few fatalities. Families and inmates would say otherwise. And when you look at those types of temperatures that are being reported, it's not surprising that we're seeing an increase in mortality. On Sunday, we saw the prisons in Stillwater in Minnesota. There were 100 of them that they were understaffed. They were in cells where it was documented to be 95 degrees. Because they were understaffed, they were pushing all of the men, and this is very common, back into their cells so they could manage them, which meant they weren't getting water breaks, they weren't getting ice. The men refused to go back into their cells and caused quite an incident, extreme heat. And then this morning I woke up and saw that as of today, all Texan prisons in the state are no longer having any visitation rights. They're under a lockdown, the entire state. Why? Because they say it's drug-related. It may be. But we also know that they have had 16 homicides within the prison this summer. And we know that heat and the symptoms and the diagnosis of these men's higher risk are very likely being exacerbated by heat. But that connection has largely failed to be made. We also have workers. We know that workers, especially outdoor workers, although I'm kind of moving past outdoor workers because I'm now talking to workers who are working inside that are adversely impacted by heat. Last week we had a Kroger employee in Kansas die from heat-related. He was working in a section that was documented 110. In June, we had a mail carrier in Dallas die from heat, a farm worker in Miami. We have had workers all over dying from extreme heat. Yet, this is not protected by OSHA. There are no protections for workers in these circumstances. And then, back to Texas, as they're now, I think, HB 2127 that Abbott signed went into effect September 1. So now we have no longer guaranteed water breaks for construction workers. This in a state that has the highest mortality for outdoor workers. It's a humanitarian issue. And then, of course, there's the water on the border issue. We had a very brave medic on the border step forward a few weeks ago, turn over an email that showed that they were being told, medics along the border were being told to push the migrants back into the Rio Grande and to deprive them of water. That's a death sentence. This is a humanitarian issue. And just for the record, both of these cases, outdoor workers, 6 out of 10 construction workers are Latinx. These are, of course, migrants crossing the border. And then there was, last week, popped up the case, what the media is calling the mystery of the missing water. With the number of deaths, last count there were 50 this summer along the border from heat. And those are numbers that have not yet been verified. I suspect it's higher. They haven't found all the corpses yet. That usually happens in fall. Humanitarian groups went out and strategically placed barrels of water to save lives. And guess what? They're missing. It's the mystery of the missing water. And then there's the Los Angeles writers' strike that some of you may be familiar with. Writers went on strike and began picketing in front of Universal Studios. On the left, on my left, you can see the tree canopy. That's what they were picketing under. The The next day, Universal went in and removed the canopy, thereby forcing the picketers to walk in the sun. So what we have in all of these cases is extreme heat has become a political weapon. It's also become a human rights issue. And lest I be remiss, Universal Studios was subsequently fined $250 for cutting down the tree. I'm going to move on, in the interest of time, to the good. But we could go on. One of the groups that haven't covered are the homeless. About half of the heat-related deaths that are currently on record result from the homeless community. And some of the practices that we're seeing, some of what we've seen this summer, Phoenix, never seen it before, physicians are overwhelmed, their burn units are overwhelmed. People are falling out of wheelchairs with third-degree burns requiring surgery. You're homeless, you fall asleep in the shade, you wake up at a temperature that's 110, the pavement is likely to be anywhere from 160 to 180. It's unbelievable to see these injuries and wounds and the deaths associated with them. And yet, we have hospitals that are creating hatred architect, where they put purposefully bands of steel so that you can't lay down on the homeless community. So there are other wicked problems that I'm sure will continue to unfold as we move forward with the story. The good. They say, I guess, let me say one other thing. So I became so outraged, I guess is the best, about what was happening and the failure that the media's been covering is, I talk to people and I ask them, hey, what's going on with heat? What are you thinking? Almost everybody can cite July was the hottest temperature ever. That's an important statistic. There's a place for it in terms of conscientiousness. But this other story is fragmented, disconnected, and not part of the media discourse. So I met with a reporter with D Magazine, and I said, we need to change this narrative. So he is beginning, he's beginning to do it locally, and I hope that we can get traction for that moving forward. Okay, the good. So we're starting to get some resources in place, finally, and the context of that is none of this is new. The scale and the magnitude is new, but that's because climate change is here, right? We've had this data. Last year, heat.gov was released by the government. It's a good site. There's some surveillance issues because the data is skewed, but there are resources and information and literature and funding. We're starting to see some grant money come that way, so that's encouraging. It's positive. We also have had, a couple of weeks ago, a new data tracking system was released, not using the ICD codes I mentioned earlier. It's using EMS 911 data. And so that won't tell us anything necessarily about mortality from heat, but it will give us a better handle on morbidity. So I think that that's hopeful. It's an interactive, you can go on as a public to look at this data. The other encouraging thing that I see are chief heat officer positions. In 2021, Miami-Dade put the first one in position. At the beginning of the summer, there were 7, by the way, all female purposely because women are disproportionately impacted by extreme heat. And I haven't kept up, but there have been a couple of other cities, one of whom has brought on the mail. And I think what's really encouraging about that trend is that these positions at the municipal level are designed to look at the wickedness of the problem. So they're looking at the built environment, they're looking at water quality, they're looking at ambient temperature, health, and that's where it's going to take this interdisciplinary approach. So I think that's an encouraging sign. And then I just wanted to mention real quick, so I'm getting low on time, the planetary health report card. I think this is really encouraging. Several years ago, medical students were very disenchanted with the lack of education and training that were being provided. So they were really savvy, and I think this is my hope, this next generation. They got together using their tech savvy and their social media skills, and they created a metrics for evaluating medical schools in terms of sustainability, and I think there were 4 criteria in terms of courses offered, interdisciplinary work, etc. And so they began posting these rankings, these report cards, and have gotten great traction. And I think this is encouraging not just for the obvious, but I think it's also one of the ways in which we need to begin thinking, rethinking solutions. Okay. Prescription for change. So we need to change the narrative, and we need to change the narrative away from, we are in a society of extremes. So when you start talking about breaking records for temperature, that's not going to, in my opinion, get it. You have all those people flocking to Death Valley to experience that. Don't even get me started on Burning Man. But the bottom line is that the message is that this is a public health issue. It needs to be treated like that in prisons and among workers and on the border. This is something that is not extraneous from everything else we do in medicine. I also think that because most people can relate, I think there's traction with using this medicine and health and heat as a way to disrupt what currently exists. I mean, for the last 30 years, we've known all of this. We continue in this spiral. I'm really afraid that at the end of this summer, when it's not so hot, this is going to go away. That's the pattern. That's the cycle. We see it with domestic violence. We have to disrupt this. And then finally, because I just got my red card, a couple of things to think about. The One Health paradigm, if you're not familiar with it, that's what we all need to be using. It's an approach to looking at health by uniting environment, people, and plants and animals and soils. The University of Arizona just got from the state almost $10 billion to develop a One Health plan for the state. That's encouraging. Structural determinants of health. In health, we typically talk about health disparities, the individual, what's your demographic, your poverty level. Well, this is what Dr. Mann was talking about earlier. Structural determinants of health is a new vision. It's about placing accountability on industry. And so this is an encouraging thing to bring into the narrative. And then I'll conclude, because I'm out of time, with the silos. And I just want to say one thing. I hesitated to put that there because we talk about, yeah, we need to get rid of the silos. It needs to be interdisciplinary. Think about what I just said, what we just talked about with the human rights issues. Nobody's reporting on the aggregate. We're still focusing on these fragmented, disconnected pieces, and that's where you're not going to get change. So thank you very much. I look forward to talking to you.